Welcome back to Dental XP. While walking around the exhibit hall earlier today, I saw that there was a new textbook on the art of the smile. And while looking at it at Quintessence, I noticed the cover was kind of the same but different. In fact, it was just the yellow version. And this is the art of the smile. Many of you remember from the original version in 2005. The new version is incredibly exciting, and really one of the major contributors to this was Dr. Andre Sadoun. Andre I've known for many, many years. He was with me, and Henry Salama, Maurice, and many others, Ed Rosenberg, that you all know from XP at the University of Pennsylvania. And he's been gracious enough, because I asked him to remove some of the material from that book that's so critical, and try and give you just a little of that information and share it, the crucial aspects. So we really do welcome him. Thank him for taking out the time, and I'm sure you can enjoy the latest from the art of the smile.
We'll be speaking today about practical strategies in achieving ideal aesthetic in implantology. Osseoingration is not anymore questionable today. It is obtained if we respect the different basic principles, but aesthetic predictability in the anterior zone is a different issue and much more difficult to achieve because of anatomical consideration, biological parameters, high responsibility of the clinician, and high patient expectation. Our goal in implantology today is to achieve ultimate aesthetic in the anterior zone with implant restoration as we can achieve in conventional aesthetic dentistry. We have a case here where after periodontal surgery we end up having some gap between the teeth, but as soon as the restorative dentist, Dr. Kubi, has inserted his laminate veneer, after a few weeks, by respecting the distance from the contact point to the peak of bone, we were able to achieve the papillas fitting totally the interdental spaces. So this is our purpose today in implantology. But as in dentistry, the soft tissue plays a very critical role in the visual perception of the anterior restoration. Without a pleasing gingival framework, even the most skilled restorative dentist and ceramist cannot predictably deliver an aesthetically pleasing result. And the reverse is also true. Without an implant restoration respecting, reproducing the optimal harmonious natural tooth gingival contour, it is also impossible to achieve an aesthetic outcome. As you can see on the slide on the right, we have two implant restoration. The soft tissue is beautiful. We have done a connective tissue graft, but the dentist did not put the zenith on the right position. Instead of putting the zenith on the left, on the distal corner, he put it on the mesial. And you can see on the left side of the screen that we have an implant restoration, and we were able, by making a slight depression on the final restoration, to obtain also the same defect, gingival defect, like we have on the adjacent tooth. In other words, we can today do whatever we want with the gingiva, depending on the shape we give to the restorative work. Therefore, functional and mainly aesthetic result and success in implant treatment in the anterior zone depend not only on the aesthetic quality of the restoration, but also on the final margin, gingival margin, and proximal papilla and contour and stability in harmony with the adjacent teeth. It is important to remember some implant parameters, and from there we will define why we do things. The key for success for aesthetic implant restoration are the following: a detailed pre-surgical diagnosis of the smile and on the implant site, a very precise and not traumatic surgical technique, a pre or per surgical bone preservation and augmentation, a pre, per or post management of the implant soft tissue. Then it is important to put the implant in an acute three-dimensional implant position and orientation. In order for an implant to be integrated, it has to be stable on the time of the implant placement. Then we have to follow the integration mechanism depending if we put an implant immediately, if we put a delayed implant, or we put a late implant. Then we start working on the soft tissue with the emergence profile, which is going to be induced by the abutment, by the temporary crown, by the final restoration. It is important also to control the force of occlusion, because we know that the teeth do not fit the same way like the implant. They have no PDL. The material we are going to use for the restorative material should be biocompatible. We should achieve an aesthetic quality with the ceramic restoration, which will give us a harmonious soft tissue long-term stability. So the pink aesthetic score in implant is very important. We can have the best restoration, but if the aesthetic contour and margin and papilla are not present and in harmony with the adjacent teeth, it will be a failure. So let's talk about the peri-implant soft tissue recession. What we know since many years today, which had been confirmed even recently in an article from Rompen in 2007, is that the majority of submerged implants lose between 0.9 and 1.6 of crystal bone after the first year of exposition and function. And it used to be a location of the crystal bone at the third thread, below the microgap. This ongoing gingival recession reveals, in a way, the fragility of the peri-implant structure, bone and soft tissue, and also creates an aesthetic prejudice without jeopardizing the functional aspect of the restoration. Because if the bone is going to be resolving by 0.9 to 1.6 millimeter, automatically the gingiva surrounding that bone will follow this resorption, and we will end up having gingival recession. And in fact, 80% of the case will have this gingival recession between 0.7 and 1 millimeter, depending on the quality of the soft tissue, depending on the quality of the implant. So this is a kind of irreversible or irreversible type of phenomena, biological phenomena. There is a kind of criterization around an implant, not only on the proximal as we thought for many years, but also surrounding the implant buccally, proximally, and palatally. And this phenomena will be more dangerous for aesthetic when we deal with thin soft tissue and thin cortical plate. For example, here on the thick biotype, even though we see some bone resorption on the proximal on the x-rays, well, the final result in the soft tissue does not see too much gingival recession. We have a limited gingival recession. On the reverse, on a thin biotype, as soon as we put the implant and put the temporary crown, then by the time we put the final restoration, the height of the gingival tissue around the lateral is much higher than the central, which should be the reverse. The lateral should be lower than the central and the canine. So this phenomena, regardless of any surgical procedures or what type of current implant design surface is selected, this bone loss is a kind of unavoidable biological process, and soft tissue will occur. This is why it is important to understand all these multifactorial factors which are involved in the biological reformation, about the bone resorption, the soft tissue stability and maturity. And we have to, in a way, by understanding these parameters, able to overtreat or maybe prevent this, minimize this phenomena to occur on our patient. These are the multifactorial parameters of prevention. There are 11. We are not going to speak about all these 11 points because we are limited for 1 hour. But we are going to speak about the thing concerning the patient biotype and the soft tissue. As a periodontist, soft tissue is very important for me, and we need to know how to manage, how to detect what we are doing and what will happen when we do things and not doing other things. So the patient biotype is the main things. As soon as we open the mouth of the patient, we can define immediately if we are dealing with a thick or with a thin biotype. If the patient has square teeth or triangular teeth. We know that with inflammation, we are going to have no gingival variation on the thick biotype, when on the reverse, gingival inflammation is going to induce gingival recession on a thin and scalloped biotype. In other words, the thicker the buccal plate, which is under this gingiva, the less bone resorption we will have when we put the implant, and the thicker is the gingiva, the less gingival recession will occur. So already we think about that if we increase or we change the biotype from thin to thick, we can already prevent some of these phenomena to occur. We know from an article from Bisada in 1987 that in teeth with subgingival restoration, the amount of gingival recession will be much more significant when we have a narrow zone of keratinized tissue. We know also that peri-implant and periodontal tissue are different to resistance to bacterial infection. Therefore, it is necessary to have a zone of keratinized gingiva around the implant on the aesthetic zone, because all the restoration on the aesthetic zone should hide the emergence profile. So it is a prerequisite to have a nice zone of keratinized gingiva. And an example here to show that on a thin tissue, even though the restoration was beautiful, it was flat at the emergence, and it happened that the gingival recession occurred. When on the reverse, on the thick tissue, even though we had a flat surface of emergence profile for the restoration, nothing special did happen, and we ended up having no gingival recession, and the level of the tissue of the lateral remained the same. In a very recent article published about 2 months ago, it has been shown that the gingival tissue thickness before even doing the incision has a very significant influence on the marginal bone stability around the implant within the first year of function after implant placement, which brings us back to what we were saying 10 years ago. If the soft tissue thickness is more than 2 millimeters, then the crestal bone loss is less than 2.26. When on the reverse, if the soft tissue thickness is less than 2 millimeters, then the crestal bone resorption is 1.45 millimeters. And that it is very important for an aesthetic anterior zone. If we lose such amount of bone, it means that we are going to have a gingival recession if the tissue is thin. This is why it is important to know in advance the thickness of the tissue. It gives you in the same time an evaluation of the marginal bone loss after you do the surgery, even before even opening the site. Consequently, the influence of the soft tissue thickness on the crestal bone changes around the implant and is more important to consider with the patient biotype before any implant placement, especially in the aesthetic zone. And this study has published, as I said 2 months ago, has definitely a very significant theoretical and clinical implication. So if the bone on the buccal and the implant is well placed and the bone is thick, then even though we do have this circumferential bone resorption, the gingiva will stay at the same level and the tooth will appear the same way. On the reverse, if the tissue are very thin, the bone is less than 1.5, the tissue will resorb and the tooth will appear longer because of the gingival recession. So it is very important to make this classification between the thin and the thick biotype, because all these parameters will give us and predict the different risks we are going to encounter when we work on a tooth that we are going to extract to put an implant. The biotype, the form of the tissue, the position of the teeth with a free gingival margin, the tooth shape, the square are usually with thick when the triangular one is with the thin. The bone crest position, where is the tooth compared to the emergence of that bone? Is it in the middle of the crest or is it more buccal or more palatal? All these parameters are very important. And if we try to classify the biotype in 4 classes, we do have class 1 is the type 1 with thick and flat biotype. We can see that if we extract that central incisor, we have to make a minimal invasive approach, a flapless approach, for example, put our implant in a minimal, in a normal 3-dimensional implant position, and the aesthetic result, depending on the abutment and the restoration, should go very easily if we respect that the emergence profile on this type of biotype should be flat, not very concave, as we will do if we do the type 2. And you can see on the slide on the type 2, there's much more things to do than on the type 1, because not only we have to do the preservation and augmentation, but also we do have to increase the vertical length of the tissue. We do have to increase the thickness of the tissue by making some connective tissue graft. And if we go to the final restoration, we can see I have to spend a lot of time working on the abutment connection. We have to spend a lot of time working on the emergence profile of the temporary crown before putting the final restoration. So it can take much more time, 3 to 6 months before sometime we do the final restoration on a thin biotype. Regarding class 3 and class 4, I would say that the more number of teeth are extracted in the aesthetic zone, the more the hard and soft tissue are compromised. The more difficult is the case, the more it will be necessary to do the site reconstruction by guided bone regeneration, connective tissue graft, decide where to put the implant, where to put the pontic, and that and other topics, how to develop the pontic site. Among the multifactorial parameters, one of them is very important because we still deal with extraction timing and implant placement. Yes. Are we going to extract all teeth for the reason that we want to put implant? My answer is no, definitely not. We try to keep as much teeth as possible. However, there is some limit to keeping the teeth, and there is two articles. One is from Mike Geyer regarding the prognosis and versus actual outcome that tell you exactly what teeth should be extracted and what are the ones that should be kept. And there is another one from Fagan, tell you also if we have a good, fair, poor, questionable, hopeless prognosis with percentage. Definitely the hopeless and questionable teeth should be removed because we don't want to have more bone to be lost. But we have to make a choice, and this choice should be done in a very honest way for the patient, not over-treat by putting too much implant. What we know is that when we extract a tooth, there is always removal of all the circumferential and transeptal gingival fibers, which are holding the tooth around the enamel and the cementum and giving the tonicity of the gingival margin. As soon as you extract the tooth, all these fibers are going to disappear. The PDL also, vascularization, will disappear. There will be no more nourishment to the bundle bone, which is the bone just close to the PDL. And consequently, there will be a remodeling and resorption of the buccal and the crestal bundle bone because they are the thinnest. So after extraction and implant placement, we thought that the thing will remain the same, but it is not true anymore. There will be less modification, but there still be some modification because, again, of the lack of gingival fibers, the lack of no supracrestal fiber around the implant. There is no cementum on the implant. So consequently, we will have marginal facial gingival recession and more bone loss and resorption from the buccal ridge than from the palatal. To go on in this extraction biology, I would say that after each teeth extraction or tooth extraction, the cervical bundle are lost. When the bone is thin, the vertical crestal height is lost, which is so important for aesthetic. And if we do lose the bone, we lose directly the gingiva and have a gingival recession. Everything is logic today. Everything could be explained not only to the dentist but also to the patient in a very simple way so they can understand why we have to do things and why sometimes it is not necessary. We can explain easily, giving a mirror to the patient, that we do have some situation after doing a light anesthesia that when I take my probe, if I have in a normal situation, well, my probe will go no more than 3 millimeters from the gingival margin to the crest of bone that they're not seeing. But we are stuck, we cannot go beyond. However, in this class 1, we have two subclasses. The one is when you have thick biotype, and the other one is when you have thin biotype. Showing to the patient also, you can see that the probe, even though the gingiva looks at a good level, the probe can go all the way inside because there is no cortical plate. We have a fenestration, we have a dehiscence. This is the class 2. Should we treat the class 2 like the class 1? Certainly not. Should we treat the class 3 where we start already with the gingival recession plus a dehiscence? Certainly not. This is why if we go to the clinic to see some cases, here the bone crest is at a normal level, 3 millimeters. Here on a thin biotype, the crest is even more, 5 millimeters. And when the patient has a recession, like we saw on the drawing, the crest of bone is even further up. So, careful examination and circumferential of the alveolar socket before and after extraction is very important. It is a prerequisite for you to determine if you are going to keep what you have or you have to preserve what you have and augment in order to prevent all these biologic phenomena to occur, as we explained at the beginning. And if you look to this table, it explains very nicely the different class of sounding of bone, the bone thickness, what technique we can use according to this classification. For example, if we are dealing with a thick gingival biotype, then we can just extract the tooth, flapless extraction, put immediate implant, and have an immediate loading. If we are dealing with a thin biotype in that case, then we have to be more careful because we know the bone is going to resorb. It is necessary to place the implant more palatally and add a connective tissue graft on the subgingival pouch. We can, if you have good stability, make an immediate loading also. The class 2 already is becoming much more complicated because we have to restore the missing part of the cortical plate. So it is necessary in that case to put the implant, raise the flap, put a connective tissue graft, but before we have to put some bone graft, a membrane, and on top of it some connective tissue graft. And definitely here it will not be possible to do an immediate loading. The last class is the worst. In other words, this is a case which is going to take a long time because it is not possible to replace the tooth by implant immediately. We have to recreate the alveolar bone housing, the soft tissue. So it's going to be a delayed type of implant placement, and definitely here no possibility to immediate loading the site. So we'll have a bonded bridge here, better than a removable. If we look at the difference between the management of the soft and the hard tissue, we can see that the hard tissue could be managed before or during implant placement. When, on the reverse, when we are dealing with the soft tissue, it is necessary to decide when you want to increase the soft tissue. Could be before putting the implant, at the time of putting the implant, before implant exposition, after implant exposition, after implant restoration. And we will go in detail with some cases about this different timing of the soft tissue. If we go to some examples of implant following extraction, here we have a case of an immediate implant extraction, immediate implant placement after extraction. We have to be very delicate in extracting the tooth. We have to make a kind of rotating movement to prevent breaking the cortical plate. And we try and we must put our implant against the palatal wall and slowly reach diameter toward the buccal without touching the buccal plate, because it is very delicate. And it is important, even though they say the gentling distance is about 1.5 to 2, I myself always put some bone graft in this micro gap of bone between the cortical plate, the inside part of it, and the implant.